Good morning, everyone. So we're going to talk a little bit today about multimodal imaging and a couple different cases of infectious uveitis. So I have no relevant financial disclosures. Throughout my cases, I use blacked out text. It's not to make these puzzles. It's in generally to make it so that you can learn a little bit more. I'm not trying to trick you or anything. I will reveal them later. And then if something is in yellow, it's just so that you can click and read it. So goals today, we're going to review the current uveitis toolbox and treatment kind of pathways. We're going to discuss a series of infectious cases, review findings that are on OCT, fundus, autofluorescence, optos, fluorescein angiography, and then discuss some specific disease treatment plans and methods for care. So we have a toolbox in uveitis. This is the top tray that I use every day at my clinic. Topical steroids like loteprednol, prednisolone, difluprednate. Sometimes we use injections like ASTK or posterior subtenon. We use implants. I use the names here just because if I put the doses, you won't know because these are very branded implants. And then systemic steroids and then immune modulatory therapies like methotrexate, mycophenolate, adalimumab, and infliximab. Again, brand names just so that you know what we're talking about. We have another toolbox in uveitis. This is for our various infections, headed up by a bunch of different antibiotics, things like trimethoprim, sulfamethoxazole double strength, doxycycline, azithromycin, valacyclovir, valganciclovir. Frequently we'll use IV antibiotics with ID if we're talking about something that's more in the endophthalmitis range. We have various intravitreal injections at different concentrations that we can use along with our retina colleagues, and then also systemic steroids that we use in these cases. So case one is a 73-year-old black male born in Wisconsin. He came to me with 3 months of floaters and blurred vision in both of his eyes. He's had swollen eyelids for 1 to 2 years, which I think tells you a little bit about chronicity here. Last month, he was found to have something before he was referred to me, and I just removed that because it makes this case a little bit too straightforward. And in his uveitis review of systems, he was an IV drug user back in the 70s. So base exam, he's got a slightly decreased vision in the right eye of 20/40. The rest of the exam is really not stand out. His slit lamp exam, he has prominent lacrimal glands, a little bit more on the left than the right with a little bit of ptosis on the left. Rest of his anterior chamber is totally quiet. No cell. He has a little bit of cataract on both sides, some syneresis, but no cell in the vitreous. So these are just a couple of photos of these lacrimal glands that I've been telling you about. You can see on the top photo, the left one is a little bit more prominent. There's a little bit of ptosis, and then kind of on the zoom in here, you can see they're firm. They aren't nodular. When you push on them, it does just feel like enlarged lacrimal glands, and he's not in pain when you push on them. Dilated exam revealed 2+ disc edema in both eyes with no hemorrhage. And then if you look further into the periphery, especially in this right eye, there's appearing to be an inferior nasal area of pigment clumping that does look like bone spicules. So I'll show you, these look a little bit blown out on my screen down here. I hope they came through okay for you up there, but if not, he does have a little bit of disc edema that we zoomed in on there. It's 2+, there's no obscuration of the vessels, and then inferior nasally, there's this pigment clumping that does look like bone spicules. Notably, it's not in a wedge pattern, so it's probably not vascular down there. This is OCT of the right eye. If we look at this OCT, at first glance, you may think this is a completely normal OCT, but I want you to look a little bit further at these. If you look at the ellipsoid zone, especially temporally, and then through the fovea, there seems to be kind of a moth-eaten irregularity through it. So there's some kind of outer retinopathy that's developed in this patient. This is the eye that had the 20/40 vision that we were talking about before. We did a autofluorescence, and I didn't include it because it doesn't really show anything different. It's normal. And this patient actually agreed to do a fluorescein with me at his next visit, but I never saw him again, unfortunately. So in uveitis, we like to talk about very complex cases, and the only way that you're going to remember what you're doing and how to deal with it is if you start creating lists of everything you see wrong. So I often put down every single finding in my exam as part of my assessment because it helps you create your differential and helps you understand what's going on. So in this case, we have an area of posterior uveitis that has disc edema, and he's got some kind of peripheral outer retinal change in the right eye, but he also has this bilateral chronic dacretinitis. You're taught in med school something called Occam's razor, which is the logical conclusion that one thing can explain all of these findings. So in this case, we would say the Occam's razor answer is that this person has syphilis, that has old acute syphilitic posterior placoid chorioretinitis, and he has syphilitic dacretinitis, which is relatively rare. Or we could say he's got Hickham's dictum. Hickham's dictum is that patients can have as many things as they want to explain their different diseases. They live long lives. They can have 2 or 3 things going on. In that scenario, we have something completely different. Maybe this is an azor that he had in the past in this right eye, and then he's got some unrelated chronic dacradenitis, probably sarcoid, but maybe something more infiltrative like lymphoma. So this is where we start to create kind of our differential, because you can see that we need to cover all of those bases. You don't know for sure which scenario you're dealing with. So for workup for these infectious things, you should always get the RPR. You should get a specific syphilitic test, either in TPPA or in EIA with IgG and IgM. The reason that secondary test is important is that if someone is very positive for syphilis and their RPR is off the charts, it will read as normal. So you need to get the secondary test to make sure that you're not dealing with someone who's acutely infected. Quantiferin TB Gold has become the standard for checking for tuberculosis. Looking for syphilis, we can check angiotensin-converting enzyme lysozyme in a chest x-ray. And then because of this dacradenitis, we wanted to follow up with an MRI orbits with and without contrast. So the thing that I kept from you at the beginning of this case, that this patient was already established with neuro-ophthalmology outside, and he'd actually seen me just after being released yesterday from being inpatient for his 14 days of IV penicillin. So at the very least, he's been able to get his antibiotic care. RPR during that admission was greater than 1 to 256. I was actually surprised that this read with how high it was, but it did read. And then his positive IgG and IgM on his syphilis EIA. We heard yesterday that we were talking about in checking these patients when they're syphilis positive, you need to check for HIV, and you really, really do. A number of my patients in my clinic are positive for both, so you do need to look for both of these. In this case, it's negative. And then he had a negative hepatitis panel with that history of IV drug use he told us about. So let's talk a little bit about ocular syphilis. Treponema pallidum is a varied presentation and should be suspected in all cases of uveitis on presentation. Every single patient can have syphilis. My mentor used to say, if you were born or have been alive ever, you need to get checked for syphilis. She also used to say it's not negative until it's negative 3 times. So just for repeat testing if you have any kind of suspicion. Misdiagnosis can have devastating consequences in syphilis. Ocular findings present with secondary or tertiary neurosyphilis. And treatment is the 10 to 14 days of IV penicillin with delayed steroids to control the ocular inflammation from that Yarks-Hersheimer reaction you memorized from med school. Variety of posterior presentations include ASPPC that we were talking about, as well as indolent retinitis. This is a case of mine from residency that I just wanted to show so that you understand what secondary syphilis can look like. This is a classic macular papular rash from syphilis. It's on the soles of the feet as well as the palms of the hands, and those actually shed syphilis. So this is why you won't meet a uveitis specialist who will shake their patient's hands without a negative RPR or TPPA first. You can catch syphilis from this. Interestingly, in this case, this patient was ASL and was signing to me the entire case, and it's one of the cases I wrote my fellowship application for because I didn't see this rash when I was a resident, and my uveitis attending came in when I called for panuveitis and pointed at this and went, "What's that about?" And that's how we found out that this patient had syphilis. So this is a pretty classic presentation. There are very few things that cause hand and foot rashes, if you remember back from your training. So something to think about if they're in your clinic, you see panuveitis, look at the hands and the feet, you can see their palms right in front of you. This image is from Dr. Goldstein. It actually was just recently published in a paper called Demystifying Ocular Syphilis that she and I worked on together with a larger group in the US. It's published in OII. This case, you can see more of that ASPPC type change in the retina. Superinasally in this right eye, you see that circle of whitening. It's actually just the outer retina. Optos picks that up really, really well. It is not nearly as prominent on physical exam when you look for this. In fact, you can completely miss it on physical exam if you're looking with just a 90. And then you can see actually on this case, there's also throughout the entire posterior pole in both eyes involvement, but I just think that that superinasal area pulls up is very prominent. And then these are the classic OCT findings of syphilis. They can be more prominent than that case that I showed you, with his just having a little bit of EZ-IZ irregularity. This is more of the outer retinopathy loss, where the EZ-IZ are nearly completely obliterated. It recovers very, very well with treatment. These patients go back to vision, as you know, back towards 20/20 if you treat them. So surprisingly, they can come in counts fingers with this total loss of outer retinopathy. You give them penicillin and a little bit of steroids, and it comes right back. So something to look for. The mimicker for this, or the thing that syphilis often will mimic or look like, is lymphoma. So you can see those little bumps down at the level of the outer retina. So that's something else that you need to keep in your differential when you look at this. And then this is a case of the more classic retinitis. Unfortunately, this was a case that came to my mentor after receiving oral prednisone without getting penicillin first. So we talked about how this can have devastating consequences. This is the devastating consequence. It's full thickness retinitis. You can see on the OCT, the entire retina there is sick. That's not going to recover with treatment. So if you give steroids without checking the RPR and they actually had syphilis, it will get worse. One more photo here showing the ground glass indolent retinitis that's in syphilis with these white spots. I have not personally seen these spots, but reportedly they are classic. So if you're looking at something that looks like ARN and they have these small white spots in it, they apparently tell you that it's syphilis off the bat, according to my mentor, and I've been looking for them since I trained with her. I have not seen them yet. So wrap up, we have syphilitic posterior uveitis with chronic syphilitic dacrotinitis in this case. We ordered the chest x-ray, ACE and lysozyme to make sure that he doesn't have a concurrent sarcoid process causing that dacrotinitis. He didn't get them. We did get the MRI brain in orbits because he saw his neuro-ophthalmologist one more time and they encouraged him to do so. I'll show you the results in the next slide, but it's relatively not important. And we offered him a course of prednisone, but at least he knew himself well and he said he's not reliable enough to take pills long term when we talked about the side effects of prednisone. And I really want to point out that you've got to talk about the side effects of prednisone. High-dose prednisone we talked about yesterday for the optic neuritis treatment trial is no joke. And even 60 milligrams that we use for this type of posterior uveitis or 20 milligrams can cause some severe side effects. Patients don't sleep. If they have any underlying mood changes, they can go into complete mania, even if you don't know that they have bipolar beforehand. So it's something that you have to watch for very carefully. In addition to that, it's really rough on the GI system. So if someone has a history of peptic ulcer disease, you can cause GI bleeds, which cause an admission. I had one just this last fall where unfortunately a patient of mine ended up anemic and admitted because of it. So it's something you need to be very careful for and very vigilant on when you're treating people. So he did get that MRI. It just shows lacrimal gland enlargement. It didn't really show us anything, but the good news is it didn't show us anything concerning. So we were talking about lymphoma as one of the other possibilities, and his blood work was all reassuring, at least from that standpoint before or during his admission. So I hope to see this gentleman again. It's been a year though. Case 2. 19-year-old female who was adopted from the former Republic of Georgia. She's had 1.5 months of floaters and a visual field defect in the right eye. Again, looking at the timing being very important on these cases because I'm going to show you some scary things on photos. She had a prior episode of panuveitis with retinal vasculitis back in 2019, something that I took away, and then her review system is that she has a dog at her home. Exam vision is relatively normal, 20/25, 20/20. I wouldn't blink at that if I was just looking at that, but she does have an APD, and then she has a complete inferior altitudinal in that right side. Dilated exam, slit lamp exam, she had an inferior needle track at 7 o'clock. So it's something that you can see if someone's done a prior AC tap. You should look for these when you're looking, especially if someone gives themselves a history of uveitis or that they've been managed by uveitis before. We check AC fluid very frequently in my clinic. So you need to get more records if you don't know why or when that happened. And a lot of the time, the patient won't remember that they had this done. It sounds like something you'd remember. A doctor put a needle in your eye at the slit lamp, but it's surprising how quick that procedure is and how little people remember about it. So just things to see and notice. She had 1+ anterior vitreous and then also 1+ mid-vitreous cell. I also want to point out the notation that I use there, anterior versus mid-vitreous. It's something that I picked up during fellowship and something I didn't hear about at all until my fellowship. When you look at the slit lamp and you look just behind the lens, that's the anterior vitreous. You can push the focus further into the vitreous and frequently you'll see a difference in the amount of cell. That'll tell you if the cell's coming from the front of the eye or if it's coming from something more posterior, if there's a variation or a gradient. It can really key you in and to where you need to look to things a little bit more carefully. So something to pick up and watch for. So these photos, I wanted to show you the difference between color photos or true color photos and Optos, and also the difference between having a new photographer and an older photographer. So these are both from our newer photographers. I apologize, they're not perfect, but you can see in the true color photo, which is on the left in this patient, that there's an area of indolent retinitis along that superior optic nerve. It's white there. There's also a pigmented lesion just at the edge of the photo on the top. If you look at the Optos and you have this zoomed out, this is zoomed in ×2 on our Optos. If you were just going to look at that, you might just look at that and say that's sheathing. So if you're just looking at those, if you're not doing a very thorough exam, you can very easily overlook something like this. But we know this patient has an altitudinal that's inferior. We know that this is a superior rim issue on this photo, so we've got a better idea of what's going on here. So we have a pan-uveitis. We had cell in the AC and the vitreous, and now we have our indolent retinitis, so it's pan-uveitis in the right eye. We have optic nerve head involvement with an inferior altitudinal defect, and we have a pigmented lesion superior to the optic nerve head. And we know it's been there 1.5 months, and she's not blind, right? It's getting better. There's really only one thing that does that, and it's toxoplasma. Could be syphilis, could be tuberculosis, could be another inflammatory process, but much less likely. The reason I didn't put viral up here is because she should be blind by now if that was a virus. So workup, we would do an AC tap with PCR, but we know this patient already had one, an RPR with the syphilis EIA that I was talking about, quantiferin, and then check for toxoplasma antibodies in the blood. AC tap from outside was negative for viral PCR a month ago when I actually ended up getting the records, but they weren't able to run toxoplasma due to low volume. That's really, really common in AC taps, is for them to only be able to run a certain number of things. So whenever you submit an AC tap, I would strongly encourage you to put a list of things that you want done in the order you want them done. So if you put all 4, I want CMV, HSV1, HSV2, VZV on the list, and you do 1, 2, 3, 4, frequently they'll get there and they get to 5 for toxo and they don't check it. This case, I thought toxoplasma first. I think that should have been at the top. But personally, different changes. So RPR, EIA were negative, quantiferin was negative. Her IgG was positive for toxoplasma, and the IgM was negative. So what do we do about those serum testings? Let's talk a little bit more about toxoplasmosis. So ocular toxoplasmosis comes from Toxoplasma gondii. It's a protozoan parasite. It's transmitted by contaminated food and liquid most commonly. We hear about other different transmissions, and it can go transplacental, which is why we talk about pregnant patients avoiding cleaning litter boxes, because you hear about this from cats too. But by far, food and water are the more common reasons to get this, and you can get it from food and water in the US. So don't think that this is just something from Central America or somewhere else. The risk of recurrence decreases with duration of disease, so the longer you have the disease, the less likely it is to flare, and increasing interval from your last flare once you've had it. Clinical diagnosis is based on clinical features, so elevated intraocular pressure, the indolent retinitis that gets better over time, and then near pigmented chorioretinal lesions, the classic picture of headlight in the fog. You can check these by doing ocular fluid sampling, and AC tap is frequently very positive. PCR from the AC tap is the gold standard for diagnosis of this disease, but as I told you in this case, negative because it wasn't run, and sometimes that can be tricky. You can also check some patients by serology, but I will caution you that 1/3 of the general population is positive for IgG for toxoplasmosis, so it is helpful in confirming your suspicion. So if you have a positive IgG, a negative IgM, and you've got a patient that has a classic pigmented lesion with headlight in the fog appearance, you can be pretty sure you're dealing with toxo. However, you can't be positive. That's why we talk about that AC fluid tap, okay? So if it starts doing something atypical as you're treating it, you should rethink about doing the AC tap. Likewise, I would use the negative. If you have a negative IgG, IgM, I would be pretty confident I'm not dealing with toxoplasmosis in that case. So classic treatment is triple therapy with pyrimethamine, sulfadiazine, and a systemic corticosteroid. There are many variations, and it's important for you to know these because we have drug shortages nationwide. It seems like every other month nowadays. But you can use things like clindamycin, azithromycin, atovaquone, that trimethoprim sulfamethoxazole that I was talking about, minocycline, and spiramycin to treat this. Intravitreal clindamycin with dexamethasone is used for macular threatening lesions and optic nerve threatening lesions. So it was something that we should consider in this case that was on the optic nerve. I will tell you that intravitreal clindamycin is on national back order, and I had a flare recently, a couple months ago, that involved the macula that I was delayed by 24 hours getting it from a different state. So if you're at an institution where you might treat this, I would encourage you to check with your pharmaceutical department to make sure that you've got intravitreal clinda that's not expired on standby, because I think they all expire in the next 2 months. So not good. For ease, a lot of us will treat with trimethoprim sulfamethoxazole at the double strength. That's the 1/6800 dose for 45 days, twice daily. Long-term treatment has been used. We do this 3 times weekly. You see someone's on Bactrim Monday, Wednesday, Friday, and it reduces the risk of recurrence. And we've shown that this reduces that risk for up to 20 months after that initial flare. So it's very useful in our patients when it's near the posterior pole, and we end up transitioning to this and keep them on it long-term. I'm keeping patients on longer than 2 years right now because if they flare when they come off of it, I have nothing to give them intraocularly. There's no clindamycin right now. So I would encourage you, if you've got patients on Bactrim right now that are on a great Monday, Wednesday, Friday dose, to just keep them on it for now until we get that resolved. So case 2 wrap-up, this was recurrent ocular toxoplasmosis. We had the pigmented lesion with the new retinitis. She now has optic nerve head involvement, and reflares are going to be vision-threatening. She's a very high-risk case. So we recommended continued treatment with the TMP-SMX twice daily for 45 days with taper down to the prophylactic dosing of Monday, Wednesday, Friday. I gave her a prednisone taper of 40 milligrams just to help with the inflammation associated with infection. And then if she would reflare, we have a vial of clindamycin set aside for a couple of my patients like her. Case 3. 20-year-old female immigrated from Nicaragua. 1 month of blurred vision with floaters of the left eye. She noticed a distortion in straight lines on a game that she was playing on her phone. Referring MD started her on something, and she's been improving. Review systems, and I love uveitis review systems, that's why I do what I do, was positive for working in a cheese factory, but really, interestingly, she never tries unpasteurized product, so, which I would be very tempted to do as someone from the cheese land. So she paid out of pocket for the exam, and this happens more commonly now that I'm an attending than when I was a resident, but patients will often request only necessary tests if they're paying out of pocket or a copay for your exam with you. So it can really change some of your management if they're telling you that they're not going to pay or they're not going to comply with kind of what you're doing. A nuance that I didn't know when I was going into practice, so things to think about. She's got 20/20 vision and 20/25 vision, a lot like that last case that we were talking about, nothing else on the base exam. Her slit lamp exam, she did have 4 resolving KP in that left side. KP have appearances to them. Resolving means that it looks like it's flattening out. It's no longer got that kind of heaped appearance to it. She's deep with 1 to 2 plus cell, no flare, and then this is one of those things where I was talking about the anterior vitreous versus the mid vitreous having a gradient. It looks like there's more cell towards her mid vitreous, so something going on posteriorly probably. On her dilated exam, there's some superior edema radiating from 11 to 2 o'clock in a wedge of retinitis off the nerve. She has white retinitis extending from the disc. There's sharp borders, then there's mild sheathing along the arcades. She did let me do an OCT. We were talking about kind of reserving certain tests, and if I had to pick one test to figure out what was going on here, it's not going to be optos. I have a good exam, it's the OCT to figure out how deep this goes and is the choroid involved. So if we look at this, she's got a full thickness retinitis. You can see that on the left side of this OCT image. There's some inflammation. You can actually see the white blood cells depositing along that posterior vitreous, just overlying that full thickness retina. And then you can get a hint that the choroid's not at least significantly involved. It maybe is a little bit elevated there, but you've got a lot of shadowing, hard to tell for sure. So again, I'm presenting you a case of pan-uveitis with this indolent type of retinitis that's been going on. This one has KP though, and the reason I brought her in or picked her case was this elevated intraocular pressure. We learned that there's very few things with uveitis that cause increased ocular pressure. Things that cause increased ocular pressure are typically viral, but toxoplasma and syphilis can also do this. So I want you to just kind of see that in cases like this that you should be thinking toxoplasma and syphilis, not just those viruses when we're talking about those things. And then again, we have disc involvement without APD or visual field defect that we could tell in the clinic. So for her wrap-up, her referring MD had already started her on the trimethoprim sulfamisoxazole twice daily and prednisolone drops. She's been improving. You could offer an AC tap. She refused because she didn't want to pay the price, and that's a pretty decent, costly procedure. And then also the testing is rather expensive, so she didn't want to have that done. She had previously tested positive for that toxoplasma IgG that I was talking about, so we just continued her on the TMP-SMX and started some prednisone taper for her. Last case here, just for this presentation, we have a 23-year-old female born in Wisconsin. She had a month of a black spot in the left eye, again, pointing out this kind of more indolent picture here being a month. She was seen at an outside ED, and I highlighted here in this next section the wrong use of oral steroids for ONTT. So we talked yesterday about how you could use 625 milligrams BID for treatment for an optic neuritis type syndrome. This person got 1 gram of IV Solu-Medrol times 1 day, and then got 2 days of 500 milligram oral, and that's not following that protocol in any way or the oral protocol in any way. So if this was optic neuritis, she was not treated correctly. And then neuro-ophthalmology, because that's who she was following with, found something and sent her over to me. So on exam, she has an APD. She has a superior temporal sparing central defect. She's deep with some rare cell. She has 2 plus AV cell, 3 plus midvit cell, like we were talking about. There's a little bit of haze, and then off of her nerve, we see again this picture of a full thickness indolent retinitis radiating from the nerve, no pigmented lesion in this case. And we see a lot of, on this OCT over the nerve, posterior vitreous cells coating that nerve. So you can see that it's a uveitic process if you're looking at something like this, if you see cell. Fluorescein angiogram, because I wanted to know the chronicity here. It's been about a month. She says she's maybe getting better, but we're not sure. I want to know if there's vasculitis associated with it, because toxoplasma often comes with vasculitis. We see an early inferior blocking lesion below the nerve, and then we just see some staining and leakage afterwards in that area. Retinitis is kind of expected, but there's no significant vasculitis. That's pretty reassuring. So again, we have panuveitis with indolent retinitis of the left eye, optic nerve head involvement with a visual field defect, mild associated vasculitis, and a similar differential to what we've been talking about. So we decided that this one was primary ocular toxoplasmosis. Neuro-ophthalmology found that retinitis. I offered her an AC tap. She didn't want it. She was toxo IgG positive. The rest of her workup was negative. We started some TMPS MX double strength, and we gave her some prednisone taper. She ended up doing much better. So is this a cluster of toxoplasmosis? I just showed you. I saw all of these 3 patients within the span of a week. 2 of them were on the same day in my clinic. It occurs commonly in foreign-born patients and more so in Central American origin in the papers, but it's generally believed to be declining in prevalence in the US. I see this all the time in my clinic, though. I think I have 1 to 3 of these a week. So it's something that I think you should all be watching for. I don't have a massive uveitis practice like my mentor either, so I'm just at the start. So this is certainly coming up more. I think we should probably do another epidemiologic study to show whether or not this is kind of surging, but seeing this pretty often, so I want to bring this up so that you guys can see it, because treatment is something you can do as a comprehensive ophthalmologist. You can just start them on some Bactrim if you see it. This is a paper that was published in the Journal of Vitreoretinal Diseases. I just wanted to point out because toxoplasma is one of those really weird masqueraders. So they called this paper the masquerade ball. And they showed 2 different cases of toxoplasma I want you to just be aware of, because I hadn't heard of these until more recently. In their first case, they showed a picture that looked very much like ARN. So you can see in A at the top left of the corner, there's a progression with time, but in A, there's that large swath of very severe retinitis and hemorrhage going on. In case 2, they thought that this looked more like ocular lymphoma because there's different patches of that whiteness and it didn't look quite so hazy to them. So just very interesting presentations to look for. I liked this paper too because it also had immunohistochemistry of toxoplasma, which I had not seen before. And I wanted to say thank you for listening to this first set. Oh, we have a microphone.
Oh, I was just passing it, sorry. I don't have a question.
Oh, did you want to ask a
No,
question?
I didn't have a question.
Oh.
I had 2 cases of uveitis in the 2 days before I came
Yeah.
from Western Wisconsin.
Yeah.
The first was an elderly woman sent from the ER supposedly with the pressure of 40, but I think they didn't measure it accurately. I saw her with 4+ microcystic edema, but she had uveitis from, I think she had an episode of shingles, so I suspected it. And I did get to see her quick and follow up, and her edema was resolving, and she was full of cells.
Yeah.
So I see that a lot when permadocs, they treat shingles around the face, but they don't refer them on for like an eye exam.
And it seems like the ocular type of shingles will present a week or 2 after. So if you're hearing that someone had the shingles rash and then a week or 2 later they're getting a red eye, they've got elevated pressure,
She
absolutely
didn't even
use
have a red
valacyclovir.
eye,
Yeah.
which was like shocking. But I've had another patient like that that came in with a pressure of 47 and had lost so much.
Yeah.
But then the other guy I had him on, well, he has HLA B27 positive, so he flares quite frequently. He flared just before I came. And I guess I'm a little bit concerned that I might be missing something else on him, but I attribute it to that. I had put him on oral steroids because he kept flaring so much. And then he got put on methotrexate, failed to get his prescription renewed. He was
Yeah.
on Cellcept too, as well. And he came in again, flared just with the hypopia even. I'm wondering if I could have missed anything else with the HLA B27 or if I should be testing for anything else, because I found out he was inappropriate to my two younger female ODs.
Yeah,
So
so
did I miss this, like a syphilis with it? Or-
if you didn't test for it, I would test for it just to make
Okay,
sure.
I think I did. I would
So
really-
I would make sure, but I would say that's not an uncommon case of B27.
Do you think it's more like
It's
that?
very likely in a positive B27 with the hypopion that it's a B27 disease that's just not managed. Frequently
Of course,
those
he's so
cases,
unique that I cannot
yeah, if
see
they're
the
flaring
retina very
horribly,
well.
he'll need more immunomodulation. I would actually send him to rheumatology, and he might need to see a GI specialist as well, just because B27 carries risk for things like ankylosing spondylitis and Crohn's. And frequently, if they're flaring more than twice a year, I'll put them on Humira.
I just wanted to
So
make sure I didn't miss like.
I don't think you missed anything. I would make sure you just go through your labs one more time. But I would say that's not atypical for a bad case of B27 disease.
Are there any other questions?
Thanks so much.
Yeah.
Very nice presentation.
Can you use the microphone, please?
Yeah, thank you for a very nice presentation. Could you speak just a little more about your approach to the anterior chamber sampling and your prioritization? Is it your clinical findings that guides the priorities for the lab with the smaller sample?
Yeah. So AC fluid sampling is a bit of an art, and I would say that in 1 out of 10 cases that I send in, even at my lab, which has a great response to it, I'll be told that it has low sample and that they can't do anything. So I know that was much higher at other institutions that I've worked at, where it was like 50% of the cases. So it's really tricky to get a response to anything you put in. So when you do send it in, you need to treat it kind of like liquid gold. I took a couple slides out of here that I sometimes put in when I'm talking about fluid sampling, but when I take the fluid, it is guided based off of a couple things that I see on exam. If they've got elevated pressure, KP that are typically viral are going to be ones that are diffuse on the inside of the endothelium. They're not in Arlt's triangle, so they disobey that rule of saying an Arlt's triangle. They're typically stellate. I'll often get it if someone has an iris paralysis sector, so you're thinking something viral, or if they have TIDs as well. With the elevated pressure, recurrent inflammation. I also get it in patients who have any amount of heterochromia, where we're trying to see, is this something that's going on from a viral stance? So I get slit lamp photos beforehand also. When you actually do take the fluid, I do it at slit lamp. I know some people will do it at bedside, and I've done it at bedside before, but I just think you get much more controlled fluid release by doing it at the slit lamp. And sometimes they'll get, when they're inflamed, a hyphema at the same time that you'll need to treat. So, and frequently it will leak just because they're inflamed, even if you've used a very small needle. So a lot of the time they'll need antibiotic and a contact lens to close the wound. And then the fluid that you get, when you put it in the vial and you're sending it in, make sure you put the label on both the syringe, but then also on the plunger, so the plunger can't accidentally be depressed by whoever is carrying this, wherever it's going, the male person, the person in the lab. Then they actually have to get scissors out to cut the label off to get the fluid out of the vial. That's one way to decrease loss of fluid on the way there. In terms of ranking, it's based off of which things I think are most likely. So if we're talking about HSV 1 and 2, there's nothing that makes me think 1 over 2. That's just kind of together if you're going to get those. If we're talking about VZV, am I talking about someone who's older or elderly? Typically, someone in their 70s is someone that I'm thinking I should probably check VZV first. And then for toxoplasma checking, it really depends on kind of what else we're seeing. I think it'd be very rare to have toxoplasma in the AC without having something going on in the retina. So I typically will downgrade toxoplasma if I'm not seeing anything in the posterior pole. Does that make sense?
Yeah. Thank you.
Perfect. Yeah.
Okay. So as far as syphilis goes, the FDA is able to test in all stages. Can you hold, yeah, close?
Yeah, it was getting kind of loud, so.
Yes, it does, yes.
So for syphilis, the FDA is able to test at all stages, right?
So FTA-ABS is going to be one of those more specifics. There's kind of
Right.
two pathways, and I'd like you to test one from both. So I would put that in the same FTA-ABS and the same as the TPPA, the treponemal particle agglutination, and the syphilis EIA. EIA is becoming the gold standard.
Okay.
So if you're talking, and actually most labs will get frustrated with you if you're ordering the FTA-ABS, even if they offer it, and they'll want you to start switching over because it's a more expensive test than them running the EIA.
Okay.
So I would talk to your institution that's running the lab. There's a very popular EIA test that's out that's branded as SIFT that most institutions are switching to. It's rather cheap. So I would just check what they want to do. Did that
Okay.
kind of answer
Yep.
what you were
Yeah, because I was thinking, well, why run the RPR if the FTA is able to test in all stages?
Yeah, you want kind of the sensitivity and then also the specificity. So you
Okay.
want both. The issue with the RPR, though, is that if it's sky high, it just won't show up on the RPR. So you kind of want both for it. And ID likes to have both, so you're going to work with them.
Okay. And the second question is, I typically, for those with zoster, I'll check them at, one day following presentation, 1 week, 1 month. I mean, what's your follow-up pattern?
Are you saying for like dermatomal V1 zoster with no
Right,
ocular involvement, or
right.
that already has uveitis?
Yeah, it's periocular.
Just periocular?
Yeah.
I think if it's periocular, when you get the referral, you should see them right away.
Right.
You'll catch ARN in a number of patients with that. I think that after you've seen them once, I would treat it similar to how I treat a PVD. I would see them if they're developing symptoms, but I would generally check them at 1 month and then again a couple months after that just to make sure it goes away.
Okay.
So that's kind of my pattern is a month and then 3 months.
Okay, thanks.
Sorry, we have one more question. We're only taking time for me. I'm okay to take it because I'm the next lecture too. So it's okay.
My question's pretty fast. You sort of joked that we should all do screening for syphilis, and I wonder if that is like a policy change that should be advocated for younger people. And it's interesting, we're in Minnesota where there's an epidemic of syphilis right now, and maybe we should do some more preventative screenings. And your thoughts about that?
So Milwaukee is actually where I work is the highest number of syphilis per capita right now, according to the World Health Organization. So strongly recommend that, yes. So anyone with uveitis that you're seeing, I would screen for syphilis, period. If someone's sexually active and it's in a high-risk area, I would think that the PCPs should probably start checking for it again. It's infinitely treatable with penicillin.
Yeah, just a quick question on the syphilis. How the syphilis testing? Do you actually test 3 times if you?
So
got
I counted
negatives?
this twice with RPR plus the other one, and then if I think that something looks like syphilis in the retina later, and both of those are negative, let's say I saw that ECIC change that we were talking about for ASPC, I would check it again. So I do get 3 times.
Okay, so moving from infections, Dr. Randerson's down to speak about pediatric uveitis and biologics.
Can you say this in the microphone so the people that are watching via live stream can hear what you're saying? And we need you guys to speak up a good bit too. Thank you.
Okay, nobody's ever accused me of not being loud enough. So, all right, so switching from the infectious realm, we're going to be now talking about pediatric uveitis and the biologics. And if you notice on the schedule tomorrow, we have a rheumatologist that I asked to come in and speak in more about the maze of all of those biologic agents. So Dr. Randerson, take us.
Absolutely. So my other hat that I wear for Medical College of Wisconsin is that I work at Children's Wisconsin, which is next door. So I have a clinic in our pediatric department where I see kids directly. I have no relevant financial disclosures for this talk. And it's important because when we're talking about these medications, every single one of them is branded. Now that we're talking about biologic medications, every single one is a brand name. I'm going to show you the alphabet soup that we deal with on a couple of these, but you won't know any of these meds if I don't use the brands. So we're going to talk about complex cases in pediatric uveitis and the lifelong complications that can come from undertreatment, review current treatment plans and biologics used in children and the limited data, and then discuss screening and referral guidelines. So we talked a little bit about this top tray of the uveitis toolbox. I'm going to show you my kid-friendly version of it now. In the kid-friendly version, we don't use difluprednate. It causes way too much steroid response, and even prednisolone makes me a little bit wary when other people aren't checking someone every 2 weeks on this medication. We use a lot of systemic steroids in kids, and then often we'll use sub-Q methotrexate. The pills do not work with kids. They can't take them. There's too many of them, and they're really hard on the stomach. We don't even touch mycophenolate because it's twice daily dosing. And we frequently use biologic agents in adalimumab or infliximab. Brand names are Humira, Remicade, or Inflectra. So pediatric uveitis is scary. These are photos from my mentor, Dr. Goldstein. I want to just show you that the right eye here is not as bad as the left eye, but I don't like seeing this, this right eye, this patient's right eye either, so it's the one on the left on our screen. And we'll zoom in and I'll show you why. This right eye in this patient has posterior synechiae, nearly 360. In kids, they can be very subtle. It's not that bright white. It's these fibrous bands that are developing that are very, very small. You can see them nearly 360 in this case. And then in the other eye, I'm going to show you something scary, and my goal by showing you this photo is to scare you. So this photo has 360 synechiae. This is a slit beam showing you that there's also a Bombay-like appearance to the iris in this case. There's band keratopathy, nasally and temporarily, that I didn't show you on the other photo. And then if we go forward, this UBM shows you that vaulting of the iris, and it will actually reveal that that's a pseudophakic lens that's syneeked down there. So we're headed towards cocooning that lens, and this eye is not doing well. So let's start talking about the bread and butter first, but I just want you to see those to be scared. This is a 3-year-old Caucasian female, separate case, not the same person, who developed left knee and right ankle pain at age 2, stopped walking. She's JIA diagnosis, and she's ANA positive from her rheumatologist. She's been given intra-articular steroids to treat an NSAID. That's a very common treatment pattern. They frequently won't start kids on those immunomodulatory medications unless they fail this multiple times. So I often see kids that have had like 7 intra-articular injections and that are just on chronic NSAID. They're referred for uveitis screening evaluation as part of the rheumatology protocol. This kid is central steady maintained in both eyes, normal pressures, no APD, full visual, full EONs. Slit lamp exam showed endothelial dusting in both sides, no band keratopathy, no KP. It's important when you first meet these kids to say whether or not those are present because it'll tell you if it develops. So you really need to look for the negatives on these kids. She's deep. She has 2+ cell, 2+ flare in both eyes. She has some posterior synechiae from 2 to 8 in the left eye and also from 10 to 1030, so a couple areas of posterior synechiae. I told you I don't like seeing that already. And then she's got pigment on the anterior capsule, which is very common in kids with JIA. I do want to point out that this is a slit lamp exam and this is a 3-year-old child. You can absolutely do a slit lamp exam on a 3-year-old child. They do not only need to go for EUA. If you start training them when they're younger, I have many patients that are 2 in my clinic that sit for their slit lamp exams. They do wonderful. You just have to start training them, and you see them monthly till they get the hang of it. You will get a better exam every single time in the clinic than you will with an EUA. There's one photo from my mentor of doing a slit lamp exam in the exam under anesthesia in the OR, where they have to actually lift the sleeping child up with the trach in their mouth to be able to do the exam. My department of anesthesia will never allow me to do that. So I will tell you that that photo exists, and I will tell you that your anesthesia department will probably tell you no if you ask to do it. So you've got to get them to be able to do this in the exam room. Dilated exam was reassuring. So this is the classic. This is JIA-associated anterior uveitis. She just had some 2+ cell. She has posterior synechiae. She's ANA positive. What do we do? For JIA-associated uveitis, it's a non-granulomatous anterior uveitis. Risk factors are oligoarthritis, so the fewer joints that are involved, the more likely they are to have uveitis. Female, ANA positive, age of onset less than 4 years old. Complications include amblyopia, band keratopathy, posterior synechiae, cataract, glaucoma, hypotony, macular edema, macular atrophy, epiretinal membrane disc edema. It goes on. These kids lose vision, and we need to plan and address things now when they're young, so that when they're older, they can be sitting in this room and be ophthalmologists themselves if they want to, which a lot of these kids want to be when they grow up. So refer them for evaluation with pediatric rheumatology early, and then workup can be relatively short in these cases where JIA is clear, CPC, CMP, ANA, rheumatoid factor, B27. You should all have this if you see children in your department hanging on the wall. This is the screening guidelines. I'm not going to go through line by line and tell you. AAO has this published on iWiki. You can just grab this chart and print it. It's very easy to carry around. It just tells you who's high risk based on their age, what their ANA test is, whether they're less than 6, greater than 6, and how long they've had their disease. And then it tells you how often you should screen these patients. So you should follow this. It's a good guidelines based off of a good group of data. So what is the treatment for JA-associated uveitis? We do it in conjunction with pediatric rheumatology always. You will not find a uveitis specialist that's treating kids by themselves. The goal is steroid-sparing therapy with reduction in sight-limiting complications. We do early induction of immunomodulatory therapy to prevent these complications that they see well long-term, and the standard stepwise treatment is going to be topical steroids followed by oral steroids. And then an antimetabolite, it's typically methotrexate. I really don't see azathioprine used very much anymore. And then a biologic, typically a TNF-alpha inhibitor. So let's talk about methotrexate. Methotrexate's an antimetabolite. It blocks dihydrofolate reductase. It's dosed usually subcutaneous in children and between 7.5 milligram to 25 milligram every week. It's given with folate to reduce side effects, and there are many: fatigue, headache, and then in the cases that I don't like, and I will switch this med if my patients have hair loss, for example, or GI upset, because those are intolerable and get worse as we go. We use subcutaneous because kids just don't tolerate the oral version. These pills come in 2.5 milligram pills, so if you're telling a kid that they have to take 10 milligrams, they're taking 4 pills every week, and these pills aren't too big, but they're also not too small, so tough for kids. It's a really good starting point when kids have mild anterior uveitis and none of those complications we're talking about. So that case that I'm showing you with posterior synechiae doesn't fit great for using methotrexate because she already has posterior synechiae, right? So it's really good by itself. If you just have a little bit of cell, let's say it's your routine screening, you've got a 5-year-old, they've got half plus cell, I would think about asking rheumatology for this medicine. We recommend escalation with combination dosages of an antimetabolite like methotrexate with a biologic like a TNF-alpha inhibitor in any kid that has severe sight-threatening complications, and posterior synechiae are one of those. Band keratopathy, the other things we were talking about. Adalimumab. Adalimumab is a biologic. The originator version is called Humira. I'm sure many of you have seen commercials for that. It's the only approved biologic for non-infectious intermediate posterior and pan-uveitis. It's also FDA approved for GIA ages 2 and up. Success can be achieved with variable doses, and it's based on weight. So we use 10 milligrams for very small kids, 20 milligrams for people in the middle, and then 40 milligrams for adults. And for kids that are 8 to 10 usually, that's when they usually hit about 30 kilogram. It's dosed every 2 weeks. If we have refractory cases, we can go up to every week dosing of adalimumab. Adalimumab is an injection at home. I should say that for this so that you guys know about that. So this is an at-home pen. It looks like EpiPen. Infliximab is also a biologic, but it's an infusion. Okay, so you have to go into the hospital or an infusion center to get this. In pediatric rheumatology in our department, they go into the infusion center in our hospital. The originator is called Remicade. 70 to 80% of children who received this medication had remission with doses between 5 milligram per kilogram every 4 weeks or 10 milligram per kilogram every 4 weeks. So between 5 and 10 is a typical dose every 4 weeks. That's very high dose compared to what rheumatology uses. They will frequently use 5 milligram per kilogram every 8 weeks, so half the dose that I'm recommending. It's actually double half, so 4 times lower dose if I'm talking about starting someone on 10, and they start getting very skittish about using those higher doses unless you're working with someone who's used to doing it. So if you're working with a rheumatologist who's not used to working with uveitis, the first thing you do is you send them papers that I've linked here about using these higher dose medications. So the consensus starting dose for kids when they've got problems is 10 mg per kg every 4 weeks, and this can be escalated all the way up to 20 mg per kg every 4 weeks. I really want to caution you, there are biosimilar medications coming out everywhere in medicine right now. They're not equal to the originator medicine unless they've been tested. Typically approval for biologic medications to be a biosimilar means that they've met one indication in testing as the originator. With uveitis being very severe with higher doses, we don't necessarily know that that's true. And I want to point out that when we tested this, a group out of Cleveland Clinic checked for the biosimilar infliximab ABDA. They showed that it did not seem as efficacious as the originator in treating uveitis. So we don't know if that's dose dependent or if there's a slight change, but we know that that medication by infusion does not work as well as Remicade. We have very limited data on the other ones. A lot of people are being switched to these biosimilars, so infliximab DYYB is out now. I have many patients on it, and the good news is it does seem to be efficacious like the originator for uveitis. We have a pending publication, Dr. Goldstein, Dr. Zaga, and I, and another doctor, Dr. Morthy, about this. New one that just hit the market a couple months ago is adalimumab ATTO. It's the first biosimilar to Humira. We have zero data. There's a couple papers from Egypt that says that it doesn't work at all. So we have no idea. So case 1 wrap up, we have a classic presentation of JIA with associated chronic anterior uveitis. She does have evidence of sight-threatening complication in posterior synechiae. We treated initially with topical steroid and oral prednisone. She was rapidly transitioned to methotrexate subcutaneous 7.5 milligram weekly, plus the adalimumab 10 every 2 weeks that I was talking about. She failed taper, so once we're on those medications, we try and taper the steroids. She failed the taper off the prednisolone, so we had to escalate her to the 20 milligram of adalimumab, which we did instead of going to weekly Humira at 10 milligram, and now she's controlled at 2 months. Case 2. 3-year-old Caucasian male born in Wisconsin. At age 2.5, he developed left knee swelling and was treated with intra-articular steroid plus NSAID. Like I said, this is very common in this clinic that I run. Workup was ANA positive. At age 3, he saw pediatric ophthalmology, found 2+ cell. He was started on prednisolone 4 times a day in both eyes. At 1 month follow-up from that, his pressure was 40 and 40. So we know that steroid response starts 2 weeks after you start the medication, so you should see the patient, especially these very young kids, 2 weeks after you start the medication just to check. So I didn't like that this was 4-week follow-up, so just as a plug here, if you are starting a child on steroid, see them every 2 weeks. You don't know when it's gonna happen, and it's going to happen. It's a matter of when, not if. She was started, patient was started then on dorzolamide timolol twice daily, tapered prednisolone to twice daily. I got a phone call and they referred them over to me saying, please help. On exam with me, so this was on that dorzolamide timolol already, the pressure came down wonderfully to 14 and 19. Vision is still doing well. This is a 3-year-old who's able to do Leah blocked letters. That's really good for him. He also had that 2+ cell. This is a very common amount in this population to see, so about 2+ cell is where I expect someone with JIA who's untreated to be. It doesn't usually get too much higher, it doesn't really go too much lower by itself, so it's about 2+. And then does have a little bit in that anterior vitreous at about 0.5+. Nothing posteriorly though, and I checked that very carefully because I saw the anterior vitreous cell. So this is a classic case of JIA-associated anterior uveitis with steroid response, and they're ANA positive. What do you think we should do? Well, I told you steroid response is one of those scary things, so I want this child eventually on both an antimetabolite and a biologic medication. So, sight-threatening complication. He's too dangerous to escalate topical prednisolone, so often I will decrease it and then start an oral medication. So I start the oral prednisone to get him over to when we get these medications approved, because it takes insurance companies about 1 to 3 months to get these medicines approved. And then I did a panic phone call myself over to our pediatric rheumatologist saying, can you please start methotrexate today, because methotrexate takes 3 months to start working, and can we get this adalimumab through the fastest process you've ever done it before for this child? I saw him 2 weeks later because of the history of steroid response, so I want you to see that you gotta see him close if you got him on steroids. And he actually had gone through this really, really fast process and he got his adalimumab, but it's the ATTO that we have no data on. And you need to stand up for your patients. Rheumatologists had no idea, and frequently, depending on your state, the pharmacy does not have to alert you as the physician that they are interchanging one of your medications for a biosimilar. So I want you to just be very aware what your state's laws are. In some places they have to alert you, in some places they have to ask you, but these laws already exist, and in my state they are able to do it without telling me. So without my knowledge, he was on ATTO. Good news though, cell is coming down, he's at 1 to 2+. In both eyes, pressures are doing okay. I wrote a really long letter to them telling them that there's no data about this. I cited the study in Egypt that wasn't doing well, and it was denied. So 2 months later, as a positive, before that methotrexate's really working, child's quiet. He's on the ATTO, he's on methotrexate, he's off all of his drops. So is this an indication that ATTO is working? I hope so. I really, really hope so. I wish we weren't trying it in a 3-year-old. Next case is an 8-year-old black male born in Wisconsin, 2 weeks of light sensitivity, had COVID-19 3 months ago, and then was referred to pediatric ophthalmology for atypical corneal endothelial opacities from an outside ophthalmologist. I wanted to show you this photo, and I did the zoom out and the zoom in so that you can see this. This is with a cell phone at the slit lamp. You all have a cell phone in your pocket. You can all take photos at a slit lamp. You just put the camera down the little pipe on this one ocular, and you can take great photos. So I was able to see this patient before I could see this patient, right? Really cool, interesting type of KP here. They kind of look like cobblestones in that inferior angle. I don't know if you can see that kind of square angled pattern that they have. And that's atypical KP, right? They're cobblestoning, they're large, they're at least mutton fat. So what's going on here? They started patient on prednisolone, and what do we do for our workup? Workup in kids when you don't know what's going on, when it's not clearly JIA, should be big. You want to get blood once. You don't want to get it multiple times, so we get it big, okay? CBC, CMP, ESR, and CRP to tell us if we're doing better if we get blood again. That's what the ESR and CRP for. We're not looking for GCA. Angiotensin converting enzyme, I want to note that depending on where you're working, at the hospital that I work at, because it's children's, it's scaled correctly, but that needs to be scaled for children because the pediatric ACE level is different than the adult ACE level. Lysozyme and chest x-ray, if the kid's old enough, you don't do a CT scan in a child. You can check your RPR. I frequently won't check the specific testing in children just because I have a little bit lower likelihood unless I'm very concerned. Quantiferin, ANA, rheumatoid factor. Urine beta-2 microglobulin checks for tubulointerstitial nephritis and uveitis tinea, which is a big diagnosis that we're seeing in more populations than we expected before. A lot of papers, hot topic in uveitis. And then your institution-preferred testing for viral kind of etiologies. This can be from the blood, either by PCR or through EIA testing with IgG and IgM. This kid's entire workup is negative. So they come to my clinic 1 week after on prednisolone 4 times a day. Pressure is 29. Again, it only took 2 weeks for that pressure to go up in this eye. What's going on? They're still 20/20. Slit lamp exam shows still persistent but improving 12 granulomatous KP that are in Arlt's triangle, so I'm not thinking viral because they're low. 2+ cell in the right eye, 3+ cell in the left eye. They don't have posterior synechiae, but they do have Kepi nodules. There's rare AC cell in the solid vit of the right eye and the left eye. And then dilated exam, because we saw some cell, is normal. So what do? We make our list. This is a granulomatous anterior uveitis. There's keratotic precipitates in both eyes. There's a steroid response in the right eye. What are we dealing with? All of our blood work is negative. Well, what if we missed something, right? What if the blood work is wrong? I thought maybe this is sarcoid, maybe this is TENU still. Based off the way these KP look, they're granulomatous, they're a little irregular. This is a child. For TENU, you can check something called HLA-DRB1, and if it's positive for 0102 subtype, it is high likelihood for it to be TENU. So this child ends up being positive for that as we go forward managing his steroid response. So we go back and forth for a number of times using prednisolone, starting medications, and ends up being this DRB1 positive. So now this child's a TENU suspect. We have to get nephrology involved because TENU, the devastating thing about it, especially in a young child, is that it can affect their kidneys. Nephrology's on board and we start treatment. So over the coming 2 months, we go back and forth with the inflammation. We're using steroid, we're encountering IOP elevation, we're going up and down on our medications. We're able to start the adalimumab plus methotrexate that this child needs because he's got some severe qualities to his type of uveitis. Even though it's not the JIA, we use the same rules in a child with uveitis. By 3 months, we're able to wean him off the oral prednisone and put him on lower doses of prednisolone, and then by month 4, we were just able to start lowering his IOP suppressants, and he's maintained 20/20 vision in each eye. I don't know that we would have encountered that same outcome if we weren't so aggressive with the IMT from the beginning. So in summary, what I want you all to remember as we're thinking about taking care of kids with uveitis is screen all kids with JIA according to the guidelines. Print them out. If you're seeing kids, put this chart in your office. You really need to follow it. You can make a dot phrase if you use a system like Epic that has all of the screening guidelines in it, then you don't have to look at the chart and you just delete everything that's not related to your patient. That's how we do it in my clinic. You can refer early any patient who has sight-threatening complications developing. So if they're getting band keratopathy, if they're getting posterior synechiae, if they're getting steroid response, refer those to a uveitis specialist. They're really, really red flags, and that's how you're going to encounter that case that we were talking about for the other kid. And then for pediatric rheumatologists, know that they're your best friends. They are going through a lot of these prior authorizations for you or with you, and prior authorizations are not your best friend. Our goal for every kid is to keep them 20/20 so that they can be an ophthalmologist if they want to. If they want to be a fighter pilot, they can be a fighter pilot, the things that you need to be 20/20 for. So start medications early in these practice. And thank you for listening.